Let me walk you through one of my typical exit conferences. I need to first explain the background for IRF reimbursement. Medicare pays based on case mix groups, and other insurers pay based on contract rates. That could be a percent of charges, CMG, per diem, or any combination. For today's session, I wanted to focus more on the Medicare payments, specifically for our discussion. The first step in determining the CMG is to determine the impairment group code, or the IGC. On this slide, you see the current options. The proposed CMG is typically determined by the admission liaison with assistance from the physician, or possibly the physician himself or herself. CMS expects the physician to play a role in this function, which usually does happen because the primary impairment causing the need for the rehab and the primary focus of care should be documented in the physician's history and physical. In addition, at least 60% of our patients must be admitted in certain impairment group categories or certain diagnoses, or they don't qualify for our 60% requirement. Look at the color coding in the IGC list. The IGCs that are green are automatic qualifiers, where the ones in yellow can be disqualified if certain diagnoses are reported. The ones without color are not automatic qualifiers. CMS makes it a little more complex in that when certain other diagnoses are used, a non-qualifier can become a qualifier. Now, it's important to note here that diagnoses that are not specific enough, meaning that they were not documented in as much detail as possible, or perhaps they were not coded to the correct specificity, can routinely cause cases to fail 60% compliance. For instance, you would expect spinal cord injuries to automatically qualify, but if spinal stenosis at any level is used as the diagnosis that supports the reason for the admission, it fails. The physician would need to document the cause of the stenosis, such as spondylosis due to myelopathy, to pass. Let's look a little deeper. Selection of the IGC places the patient into a payment category called a rehab impairment category, or a RIC. You're viewing 2 RICs. There are 21 in all. The primary diagnosis and the focus of care that is documented by the physician determines the IGC, which determines the RIC. Once the RIC is determined, the patient's functional score and/or age determines the specific case mix group, or CMG. The CMG options for the 2 RICs shown are in the first column to the left. The next thing that matters are the diagnoses documented and reported as comorbidities. CMS publishes a list of diagnoses that can qualify the case into different payment tiers. Diagnoses that CMS anticipate cost us more to treat and therefore can change our payment. In the columns to the right of the table, you see those tier options. Diagnoses in Tier 1 offer the highest payment potential and the highest length of stay potential. Tier 2, the second highest. Tier 3, the third. And the last column, the lowest payment option, is used for payment calculation when there are no reported comorbidities that are considered tiers. That doesn't mean there's no secondary diagnoses reported, just none of them were on the CMS list to tier you. For example, the list of Tier 1 diagnoses is very limited. It includes dialysis, trach, attention to trach, laryngeal edema, and vocal cord paralysis that is specified as either unilateral or bilateral. The biggest opportunity we see here is when the physician documents the patient with a history of a trach when they were decannulated just days before the admission to the rehab. And coding rules only allow interpretation as no longer existing or requiring treatment when that physician states history of trach. But if there were still ongoing care provided for the stoma and the physician documented that with more clarity and associated that diagnosis to the treatment, the tier could be captured. Documented as history of course, does not clearly describe that the patient was recently decannulated and the wound care will need to continue. Now, looking at the tables, if the CMG was 0106 and that documentation did not correctly support the fact that the patient should have been a B tier. Rather, we reported as an A tier. You see an opportunity for about $12,000 based on national average payment rates that you see here. Tier 2 diagnoses, they're very limited options as well, dysphagia, C. diff, and Pseudomonas. Many times in the record reviews, we see that physician does not identify the organism for infections, even when there was testing that provided the answer, or they do not reiterate information from the speech therapist, all causing tier loss opportunity. The Tier 3 diagnoses include a long list, but the ones most often missed are diabetes with manifestations. That means my physician may have documented diabetes and all through the record identified the fact that the glucose values were 42, 56, 542, but never stated the words hyper or hypoglycemia, and just that one little element causes us to lose the tier opportunity unless there is a query performed. Other situations, if the physician did not provide the specificity of a diagnosis, such as congestive heart failure, if he didn't identify the fact that it was acute, chronic, systolic, diastolic, left heart, then just simply reporting CHF or documenting CHF doesn't give us that tier opportunity. Or perhaps the physician may have downgraded an infectious process like sepsis, where the patient had sepsis and acute, and we brought them over to rehab, and we were continuing to treat that sepsis, maybe still have the patient on antibiotics, and that condition, the word for that condition, the diagnosis that the physician has stated, gets downgraded to something like bacteremia or urosepsis. There is no diagnosis code for urosepsis. It's reported as a UTI, which is not a tier, and bacteremia is also not a tier. If they, of course, had those comorbidities but were not documented appropriately, then that changes not only our option for longer lengths of stays, but our option for increased revenue. Here, let's say, for example, we had a patient who came in because they had neoplasm of the brain and they had brain surgery, and now they're coming to rehab. They were 72 years old and their motor score, their functional motor score was 42. So if you look at the table on the bottom, that's going to put us in RIC 03. Look at where that patient falls. 0305 says non-traumatic brain injury less than 42 and an age of less than 78.5. So that's where our patient would be, right? 0305. Then our payment is going to be in that last column somewhere around $26,972. And these are national average rates. However, if the physician documented history of trach, patient decannulated, whatever day, and continue nursing care for wound management or continue wound therapy where the association of the treatment is provided associated to the diagnosis, then that's going to pull us back up and give us a longer length of stay, a potential 21 days versus 17, and a higher potential reimbursement rate around, almost 39,000 versus 26,000. So you see very quickly you can lose revenue based on not only the way the physician documents it, but how that documentation is interpreted and then reported by the coders.
Watch Part 3. How can you change the outcome? Discover your options.